I'm Dr. Rapoff of DC QME Continuing Education, and welcome to this week's presentation. Today, I'd like to explore a potentially painful and arguably annoying medical condition that we must be very familiar with as a qualified medical evaluator. And that would be a condition of stenosing tendinopathitis of the thumb, or as it's also referred to as constrictive tendinopathitis. Now, were you aware that the AMA guides makes a distinction between these two names for the same condition? Well, that's not entirely true, but there is one truly objective finding that the examinee must possess for an evaluator to opine for this impairment according to the guides. And we will touch on that one objective finding that sets these two conditions apart, or at least according to the guides, it sets them apart. Let's get started. First, these are the following sources that I referenced when producing this presentation. I encourage you to explore these references if you'd like a more in-depth understanding of our discussion today. Now let's get started. First, let's begin with anatomy and pathophysiology of the area. Now, stenosing flexor tendinopathitis is also known as trigger thumb, and it occurs due to the narrowing of the flexor tendon sheath, causing the tendon to catch during movement. This condition results in a noticeable clicking or a popping sensation when attempting to extend the thumb. It's also caused by a size mismatch between the swollen flexor tendon and its sheath, often leading to pain and reduced functionality. Now, the condition affects both the extrinsic flexor pollicis longus, the FPL, and the intrinsic flexor pollicis brevis, the FPB, with the FPL tendon passing through the A1 oblique and A2 pulleys, with the A1 pulley positioned most proximally and the A2 pulley situated most distally. We will take a look at this in the next slide. However, notably, the A1 pulley does overlap the metacarpal bone, overlapping the metacarpophalangeal joint and the base of the proximal phalanx. Trigger thumb typically results from the thickening of the A1 pulley, leading to pain and reduced functionality. Now, as you take a look at this diagram, I'll give you a little bit better understanding. As you see on the left, the flexor pollicis longus and the flexor pollicis brevis tendons, as they pass through the A1, the oblique, and the A2 pulleys. Now, the trigger thumb occurs when the A1 pulley becomes thickened or inflamed, causing a size mismatch between the swollen tendon and the sheath. This constriction actually prevents the tendon from gliding smoothly, leading to a catching or a locking during thumb movement, as illustrated in the image on the right. So, discussing the symptoms, many of the common symptoms include a popping or clicking sound during the actual thumb movement. There's pain at the base of the thumb, swelling around the affected area, with difficulty in movement, extending or flexing the thumb, especially. And also there's morning stiffness and reduced range of motion. Now here, as you see in the image on the right, that is a condition that is not just peculiar to the thumb. Its inflammation of the tendon sheaths can occur in any digit of the hand. Likewise, a trigger finger occurs when the A1 pulley becomes thickened or inflamed, causing the size mismatch between the swollen tendon and its sheath as well. This constriction will prevent the tendon from gliding smoothly, leading to that catching or locking during a particular finger movement. As you see this occurring in the thumb and the third finger in this individual on the right. So some potential causes for this condition. The constrictive tendinopathitis can be caused by several factors, including overuse, which would be a repetitive motion or overuse of the tendon that can lead to inflammation and a thickening of the sheath. Here comes to mind a cumulative trauma injury, work comp. Also, just an actual injury to the area itself, which would be a trauma to the tendon or the sheath that would result in an inflammation or a constriction as well. Also, infection. In some cases, an infection can cause an inflammation and a narrowing of the tendon sheath. And you also need to keep in mind there may be some underlying conditions, such as rheumatoid arthritis or diabetes, that can increase the risk of developing constrictive tenosynovitis. Now, in order to establish a diagnosis, they're typically made through obviously a physical examination where the doctor may observe the catching or locking of the thumb. Additionally, imaging studies such as an ultrasound or an MRI, as you see to the left here, can be used to assess the extent of the inflammation and of any structural abnormalities that would be present. Now, in referencing treatment, there are some treatment options available. First of all, is conservative management, which would basically mean rest, splinting, and physical therapy in order to reduce the inflammation and to improve the actual tendon movement. Also, steroid injections could be considered if the conservative management did not come to fruition. And this would be a corticosteroid injection that would actually help reduce the inflammation and relieve the symptoms. And finally, surgical intervention. And there are some cases where the conservative treatments would fail, and a surgical release of the A1 pulley may be actually necessary to restore the normal thumb function. And you can see this in the image presented here. The AMA guides outlines very specific criteria for evaluating impairment caused by constricted tenosynovitis. These criteria include, first of all, the severity of the symptoms. So the extent of the pain, the swelling, and the functional limitations that are actually experienced by the examinee. Then also objective findings. The clinical examination findings, such as the presence of the catching or locking of the tendon, are actually a requirement for a consideration of permanent impairment. As I mentioned, there was a little bit of a discrepancy between the definition of constricted tenosynovitis or stenosing tenosynovitis and how it is determined in the AMA guides. So this is where it sets itself apart. Those findings, such as the presence of a catching or locking of the tendon, are absolute requirement for consideration of permanent impairment. Now, also, as part of the criteria, there are imaging studies. For example, as I mentioned earlier, ultrasound or MRI, that actually can assess the extent of the constriction. And then finally, the impact on activities of daily living. So this is to basically what degree which condition affects the applicant's ability to perform their daily tasks and work-related activities. But we know that we really associate a lot of these activities of daily living with things that we perform at home. So let's take a look and see how these impairments are measured according to the guides. So on page 507, you'll see in table 1629, digit impairment due to constrictive tenosynovitis. Permanent impairment is actually measured not by the presence of pain or merely acute or chronic inflammation of the flexor tendon of the thumb, but the presence or lack of presence of the triggering action of the digit. Now, the degree of impairment ranges from a mild, which would be representing a 20% digit impairment, and that is an inconstant or an occasional or frequent triggering during active ranges of motion. The next level would be a moderate or 40% digit impairment that represents a constant triggering during active ranges of motion. And finally, we have this most severe level, which is severe at 60% digit impairment, which presents with the constant triggering during passive range of motion, not even considering active range. So the guide specifically states that a triggering of a digit must be present to at least some degree in order for an injured worker to be eligible for permanent impairment due to constrictive tenosynovitis. And this is according to the strict application of the guides. So today I hope you learned something or at least were reminded or had some review for you from the AMA guides when we're talking about this condition that is not actually that uncommon. And we're reminded that there is a significant distinction between those terms of stenosing tenosynovitis and constrictive tenosynovitis, particularly when we're considering permanent impairment according to the AMA guides. Although we know that the terms stenosing tenosynovitis and constrictive tenosynovitis are virtually identical medical terms, this isn't the case according to the guides, as illustrated in the last slide. So there is something else that we must keep in mind that in order for an injured worker to actually qualify for permanent impairment due to this tenosynovitis, the mere presence of pain, edema, and loss of motion is not sufficient to satisfy the requirements to determine permanent impairment. The worker must also experience a triggering of some degree to demonstrate the presence of a catching or a locking of the tendon. Once that symptom is noted by the examiner, then the degree of the severity of the triggering will be ultimately determine the percentage of the digit impairment for that individual. So, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you again for taking the time to join me in this presentation. I hope you enjoyed it, and I do look forward to sharing some other interesting subjects as they relate to the workers' compensation system in the state of California. Until next time, thank you.